So what I'm going to talk about is what we do on an everyday basis. And as I say many times, there's two things a good doctor does. And first is to tell the patient what's wrong, and second is to help that patient get better. To get you through what we do for diagnosis and treatment, I'm going to present this in a case format, just as you might see this in the clinical setting that you're in. This is a patient that's a 60-year-old male, presents with unilateral medial knee pain. Now right away we know statistically from all the numbers we see, we know this is most likely osteoarthritis, but how do we actually establish that diagnosis? Now I'm going to go through the history with you and talk about what I see in those different history points and what I'm thinking as I go through each step. The patient gives a history of a mild twisting injury while working at home in his yard 2 months ago. Now this is getting me oriented toward whether this is an acute or a chronic problem. Am I thinking of an injury like a medial collateral ligament sprain or a meniscus tear, or do I have a chronic problem like an arthritis or other degenerative conditions? He says the pain is on the medial side of the knee. He has some mild swelling diffusely, but there's no warmth, redness, or fever. So that swelling might be indicative of a soft tissue injury. The fact that there was none of these other signs of warmth, redness, and heat at the site says that infection is probably unlikely. But we're also thinking, if I have swelling, what am I going to come up with as far as needing to do an arthrocentesis or drain the joint? He states there's no catching, locking, or giving way. And those mechanical symptoms, of course, suggest an intra-articular problem such as a meniscal tear. When we have mechanical symptoms, that's when, in this case, we would start thinking about MRI to help us confirm that diagnosis. And I'm going to point out to you that MRI right now is not a big part of the workup and treatment of osteoarthritis, at least non-operatively. And I'm not going to mention again, I think that's important. It's not the first test or examination to think of when we're talking about osteoarthritis. But if we have mechanical symptoms, that's a good time to think an orthopedic surgeon might be brought into the loop pretty early. The patient says he had one previous episode of knee pain 18 months ago. That resolved with over-the-counter medications. Well, now I'm getting at the point of, is this a recurrent problem? Is this a flare-up of a pre-existing condition? There's no previous surgery, and he has no other joints which hurt or swell. As you know, inflammatory arthritis of different types, including rheumatoid, are most often but not always polyarticular. So I'm sort of narrowing down the things that I'm thinking of as diagnostic possibilities. The patient gives a medical history of hypertension, for which he takes losartan and hydrochlorothiazide. He describes mild GERD, which he takes a PPI on an as-needed basis. He does not take any cardiac medication. He has no renal or liver disease and no known drug allergies. So what that tells me is I'm thinking if I want to use NSAID therapy, he has some risks, but they aren't high, moderate risk for NSAIDs. And he also says if I want to use acetaminophen as part of the treatment plan, he should be okay. And that relates to the liver disease, of course. As social history tells us this, he works as an auto mechanic, so we're going to have to address the fact that he's going to need to function in a fairly physical job, and we need to consider that as part of our treatment plan. His activity goals are wanting to bike and jog, and these are fairly reasonable for someone with arthritis, but it's important for us as clinicians to understand what the patient's goals are and what we might need to discuss as far as modifications. So we might say the biking will turn out to be fine, the jogging might be a little more problematic. Physical exam is afebrile, and even though we note that, systemic symptoms in the face of a periarticular or joint infection are a late sign, and we don't want to depend on that. We also note that his BMI is 40, so there's going to be a need to discuss optimization of his body weight. And I'll say this again, but we can't make our treatment hinge solely on loss of body weight because that's a very difficult proposition for most patients, but we can't fail to address it either. His gait is antalgic, which is consistent with any sort of painful condition in the knee. We also note on exam that he has quadriceps atrophy on that side compared to the other, and a fairly poor muscle tone. So this suggests immediately that an exercise program in some form is going to be part of his treatment. So as I'm going through all this, I'm formulating where I'm going with diagnosis, where I'm going with treatment. Now, the detailed knee exam shows moderate effusion. Now, a good thing aside at this point is to say, when would we do arthrocentesis? The criteria I would use would be if the effusion is tense and painful, if the size of the effusion causes significant inhibition of the quadriceps muscle, or if I need that for diagnostic purposes, such as a suspected infection, or hemarthrosis or inflammatory disease. Range of motion of the patient is full. He has pain at the extremes of motion. It's fairly generic, pretty typical. We know tenderness on the medial side of the knee, medial femoral condyle, joint line, and medial tibial plateau. Now, I'll point out here that if you're not doing a detailed, careful exam, it's easy to say the knee is tender or the medial side of the knee is tender, but I differentiate here, I think you should as well. What we're palpating, the condyle, the tibial plateau, the joint line, and make a note of that, and that will help in this process. So those points of tenderness help us diagnose whether we might be dealing with a medial collateral ligament injury or a meniscus injury or arthritis problem. He has no pain with valgus stress, and the rest of his ligament exam is within normal limits. If he had an MCL injury, it would certainly hurt with valgus stress, so we can put that now low on our list of diagnostic possibilities. But I would caution you, the real detailed ligament exam like we might do for a sports medicine patient for looking at ACL or PCL, for example, is pretty detailed and does require a lot of experience. It's not a simple thing. Exam of the patella should always be part of the exam. Mild tenderness, crepitus. Standing alignment, we see a varus deformity. It's increased compared to the opposite side. Now that could be due to several things. We want to think of those. Could be due to a bony deformity from an old fracture. Is this due to just joint space narrowing and collapse of the medial side of the knee? And this also might lead us to think, is this patient down the road going to be a candidate for some type of knee brace? And we'll get to that in a little bit. The hip range of motion is full and pain-free. Lumbar spine motion is decreased, but straight leg raise test is negative. Osteoarthritis of the hip and sciatica are two conditions that can cause referred pain of the knee, and you should always think of those when we see that if the pain pattern is atypical. So then that quick screen would be hip range of motion, straight leg raising, lumbar spine range of motion. Now, x-rays. Really to confirm the diagnosis of osteoarthritis, we must have x-rays. You've heard that before in the shoulder, and we're going to say that with the knee as well. It's important that we order an optimal series of x-rays, and the most important thing for diagnosing arthritis in the knee is to have a weight-bearing x-ray. And every x-ray department knows how to do it, but we need, if it's not part of the standard protocol, it needs to be specified. And we prefer a series of views which might include an AP weight-bearing view and slight flexion, a lateral, and some view that allows us to look at the patella on tangent, such as a merchant view. The typical findings, as Dr. Reeder mentioned, joint space narrowing, peripheral osteophytes, subchondral sclerosis, and involvement of single or multiple compartments, and that'll become important as our speakers who talk about arthroplasty will get into later. The findings in this patient include mild medial joint space narrowing, but not the so-called bone-on-bone appearance, small medial peripheral osteophytes, mild subchondral sclerosis, and no evidence of fracture, bony deformity, or other bone or joint, bone or soft tissue abnormality. On arthrocentesis, we decided to do in this case, 30 cc's clear yellow fluid. So that tells us they're not a hemarthrosis, so a traumatic event is less likely. There's also, to see clear fluid, there's unlikely to be an infection. If we were still to pursue that, we would send that fluid for culture and sensitivity. And again, with highly inflammatory processes, that fluid would not be clear. But if we were wondering about the presence of rheumatoid arthritis or gout, we would send these for various tests, which I show up on the slide. Didn't perform any blood tests because we weren't suspicious of an inflammatory rheumatologic condition, but there are various tests that are done when appropriate, and I've listed those here. And this is also time to consider, in a more complex case, to bring a rheumatologist to get involved with the case. So in this instance, the diagnosis is mild to moderate medial compartment osteoarthritis. Now, we're going to be getting into the other scans that we surgeons use in a little bit, but I'm going to continue with the non-operative treatment. So first of all, let's consider the goals of that treatment. We want to optimize the quality of life. We want to minimize the risk to the patient, and we want to monitor the patient appropriately. In general, what we do when we treat osteoarthritis is use a combination of modalities, and those might be pharmacological, which could include oral, topical, or injectable pharmacological material, or non-pharmacological, which is modifying lifestyle, bracing, and various types of alternative medicine, which I'll mention very briefly. And the way the progression of treatment goes is in a stepwise fashion, starting with the easiest things, and if the patient does not respond, and has continued symptoms to progress to the next level of treatment. Now, we'll mention something you may have heard of, and those are called treatment guidelines. And various medical organizations around the world and different specialties have published guidelines. And what I would tell you, if you look these up, the big picture looks the same, but they vary substantially in the details. So what I'm going to tell you today is sort of a synthesis of what the literature says, what the guidelines say, and what my practical experience is in treating osteoarthritis non-operatively. I'm not going to be mentioning PRP or stem cells. Those are very new, they're promising, but there's not enough known. So the state of the evidence we want is the very top, the systematic reviews, the randomized controlled trials, but for PRP and stem cell treatment, we're just at the very level case opinions, case studies. So what's our initial treatment for this patient with mild to moderate arthritis? Several things. We're going to start with education. People need to understand what arthritis is, and I think we all have our way of explaining what that is, but it's important to point out to the patients, I think, that this is something that's a slowly progressive disease that we don't have a fix for, and you can break that to them gently, but that's the bottom line. And most of the things we do short of arthroplasty, let's say, are really treating the symptoms. The second part of the treatment is going to include some type of lifestyle or activity modification. High impact activity is not going to be part of this patient's lifestyle, at least in a big way. We want to talk about low impact and probably discourage, but perhaps not forbid, running. And if a patient has an extremely strenuous job, that needs to be discussed as well. Third, we need to bring in the discussion of optimizing weight, lowering the BMI. We can offer a dietitian consultation, and it's important to know who you might use should that patient want to do that. And again, I'll mention, we had to mention it, we need to talk about it, we need to offer the patient the opportunity to take advantage of resources, but we can't make our treatment hinge on that because that's the hardest thing we can ask them to do. I think the most important part is exercise, and I'm going to talk about how we get to exercise and goals here for just a few minutes. The level of exercise a patient will engage in is titrated upward by their level or downward by their level of comfort. So if the patient has a lot of swelling and pain after exercise, that means they're doing too much, we back off. We have several goals in exercise, and I have 4 of them, though you can only see 3. One is strength, and I'll emphasize the quad to the patient is your shock absorber for your knee. The better your shock absorber, the less wear and tear on that knee. This will help you with your weight management. This will help with balance, and in patients who have fall risk, that's important. And the 4th one alludes to improvement of range of motion through exercise. Now, how do we get there? Home exercise, I think, is a tricky issue because over the years I've seen compliance is a tremendous issue. There are very few people that I really can trust to say they're going to, I give them a sheet of exercise or one visit to the physical therapist and they will do a consistent program. Those patients who will do that are probably those that say they go to the gym 5 times a week already. Short of that, and there are people that do that, and that's great, and we should encourage healthy behaviors such as that. But for most patients, I'm going to prescribe physical therapy twice a week for 6 weeks, and that might include your conventional physical therapy in the gym, or it might include pool therapy, and I think that's a great choice for patients whose symptoms are really significant, who have limited mobility or are very overweight. But there is with the pool, it's always availability, and some people just don't want to get in the pool, and I can understand that. Initial medical treatment, acetaminophen is a good medication. We're going to very rarely get in any side effect issue unless we go over the maximum recommended dose, and except for those patients with renal or hepatic issues. Glucosamine and chondroitin are very interesting to talk about, and many people do ask. Now, the research studies and the meta-analyses are kind of mixed, but overall, looking at patients who use the combination of those 2 medications appear better than placebo. And furthermore, there's some research evidence to say that not only could they give some pain relief, but they may having some positive structural effects on articular cartilage. So it's something to think about. I always would recommend the patient get very generic, buy at a Kroger brand, Sam's Club, what have you. But it certainly can be part of the mix and very, very low side effect profile. Now, things like knee sleeves, patellar taping, insoles, acupuncture, TENS, those can all be part of the armamentarium you would use. I don't think they're important, and I don't think there's a lot of support or recommendation for that, but I think those are things in cases where patients are requesting. It's kind of, certainly it's a do no harm situation with all those. Now, our patient in this case says after 6 weeks of treatment that we outlined above, essentially no change in the symptoms. So what do we do next? Well, the next line of treatment I would add as a second line NSAIDs, and I think in the climate we have now, knowing every year there's more evidence that NSAIDs and every other drug has side effects, and some of those serious, you want to continue to use the lowest dose and the shortest course that you can. Use with a protein pump inhibitor if needed. There's some evidence that naproxen, naproxen is somewhat safer in that regard. I always would try 2 medications because there is a variable response. Some patients like ibuprofen. Some people feel naproxen is better. It's always worth trying. The disadvantage with using these medicines is the side effect in the renal, GI, cardiac, high blood pressure. So I like to stay away from medicines as much as I can. Topical NSAIDs can be useful, or lidocaine patches, and those particularly in patients with higher medicine risk and in older patients who we don't want to go further with. Opioids are always discussed in these, but I think, again, the climate, the legislative and the administrative climate is such that I would not use opioids for osteoarthritis, as simple as that, but you will see recommendations to bring that in the treatment plan. Post-operative, different, but in the non-operative setting, no. This patient tried 2 different NSAIDs, be regularly exercising, no substantial relief. What's next? Well, now we talk about viscosupplementation. And again, you'll see in the literature and in treatment guidelines some mixed recommendations, but I think it's safe to say we know how they work. Lubrication, analgesic, anti-inflammatory effect, and in fact can modify hyaluronic acid synthesis in the joint. There's an excellent safety profile, and so I think in the right kind of patient, and this is the right kind of patient, this is an excellent choice. It's not for the patient with severe arthritis, and it's really important that you have the appropriate technique. This injection must be given intra-articularly. It can't be in the fat pad or the periarticular soft tissues, or first of all, you have an unhappy patient. Second, you won't get the result you anticipated. What I use, there are 6 products available, I think. I use the ones that are bioengineered, not the ones made from roosters, and that to me says there's going to be no contaminants from another species, even if those are minuscule in amount. And I'll also use the type that have the longer chained, higher molecular weight, which are more closer to the native hyaluronan. Those 2 products that meet those criteria for me are Orthovisc and Euflexa. And I don't know if I'm supposed to have apologized for using a commercial reference here, but that's my apology. The Synvisc, which has the biggest market share, and all of you have heard of, does have a higher rate of local reaction. And so, about 3 to 4% of patients will have a pretty severe reaction after that. And so I don't want that, so I avoid Synvisc. And what about bracing? The unloader brace that you hear of has very good research behind it and very good results. The best candidate, though, is a very narrow subset. That patient must have a pretty muscular leg, a fairly small soft tissue envelope. We know what that means. And it's not really an aesthetic-looking brace. I had a picture on there, but somehow that didn't come up. But it's not a very aesthetic brace. So males seem to kind of look at it as I'm kind of tough and cool. Women look like, oh my God, you're going to make me wear that. So I tend, for the male who has an active job, or is an avid golfer, for example, I think, and who's got a well-proportioned leg, I think it's a great choice. Outside of that, its acceptance is a little bit lower. Knee sleeves can be helpful for compression and warmth, but they aren't covered, so patients get a little nervous about paying for that. Now, this patient did a lot of yard work, and his pain and swelling have increased substantially. He and his family have a vacation coming up where they'll do a lot of walking. Well, this is the point where I would think of the intra-articular corticosteroid injection. This is great for when the arthritis flares up, which it does, and it's great when we need short-term relief, like I'm going on vacation, I'm going to walk, I want some help. Because the corticosteroid injection works quickly, but it doesn't last very long. If we're lucky, it'd be 4 weeks. There is a mild systemic effect, so some patients will see their blood sugar get out of whack, and we don't want to do any injection in any joint, any material, if there's any suggestion of infection whatsoever. And you may have heard, you may hear people say, well, what about joint damage caused by corticosteroids? And there are some animal studies and some anecdotal reports of that, but despite that, every guideline says use them, and 95% of rheumatologists use them, so I don't think it's a significant clinical problem in humans unless we go overboard like Dr. Westerheide was talking about this morning. So the patient responds to the injection, has a great vacation, but after several weeks, his pain level returns, and he is now dissatisfied. So what do we do next? Well, at this point, we bring in my other colleagues, and we call Orthopedic 1. So thank you.